for a coronary CTA, which showed that she had anomalous origin of the left main. Do you want to show that here? So we'll show you the coronary CTA. And here you can see the origin of the RCA in the left system in the next image. You can see it further subdivided, the left and the RCA.
Wait, we don't see the RCA. It's the left and the circ.
Yeah, actually you can't see the RCA, so it's just the LAD and the circ.
Yeah.
So afterwards, she underwent a nuclear stress test, which showed that it was essentially normal. She subsequently underwent a coronary angiogram for further evaluation and consideration of FFR and IVUS of the coronaries to determine the clinical significance.
So here's the right coronary artery. Is that coming across okay, Eric?
It's perfect for me. It was not good when we saw the CAT scan.
Okay, so then they had trouble finding the left system, so they did an aortic injection. And so here's the left coronary system. It actually doesn't look that bad, but it's not in the usual position. And the ostium doesn't look that compromised here. So anyway, they went in and then did an IVUS of the left main LAD. And the problem is they use the volcano system, and the imaging is really poor. I can show it to you, but I'm not sure that you can make any sense of it. Let's see which one. I think this one. So that looks. That's the catheter. So this is the left main. It does not look to me like it's narrowed, but there's a little suggestion. But there can be so much dropout on these volcano images that I don't trust this.
John, do you hear me?
Yes.
Then I think there is hypoplasia. No? In the very beginning of the artery, you see this. It's about 2.5 diameter.
On the ultrasound, you want to stay on that?
Yeah, if you want, I think you can entertain the fact that the idea that the proximal is more than compressed as the usual case of intramural coronary artery. It's apoplastic. You see, this is 2.3 for a left main is very small.
Yeah.
And there is thickening of the intima like atherosclerosis. Not an ulcer.
And I think that this is the leading edge, so it's a little elliptical rather than being circular at this point. But there's so much dropout along here that I think it's hard to tell. See, like over here, it looks like this artery, the lumen goes in over on this direction, which would be more elliptical rather than circular. But it doesn't look that compressed to me. Here, maybe this one's a little bit better. So, and looking at the CT, it seems to me, could you comment on that? It seems to me that it's kind of posterior and then comes off at kind of a sharp angle.
Can we see it in motion, going up and down?
So I would have to centricity.
Just go back to
yeah. Let me see if I can bring the workstation up.
CTA corner up.
This may take a little time to bring up.
That's okay.
So it's not that the artery is coming off of the other cusp, but it's just the placement is a little unusual and kind of a sharp angle. You know which one it is?
But it's a little posterior as origin, no?
Yes.
within the left sinus of Valsalva, but close to the posterior common, next to the non-coronary sinus. Can we do that?
There it is. Go back. One more.
Yeah.
Right there.
Yeah. It looks small in the beginning.
Yeah, that's good.
Can I ask, how did the patient present? Was there symptoms or some other functional testing abnormality or something?
Atypical chest pain, which precipitated an exercise stress echo, which the EKG portion was normal, but the echo portion, the EKG portion was abnormal, inferior lateral ST depression, 1.5 to 2 millimeters, but the echo was normal.
And did she have chest pain on that?
Yes, she had chest pain also during the test.
On the test.
On the test. She exercised to only 8 minutes, 10 mets. Her double product was only 11,000, and she didn't even reach target heart rate.
So, Paulo, this is the case that my colleague, Dr. Aksoy, talked to you about. I think we sent you the images.
You see, in cross-section, it looks like the left main is small, but it comes off the sinus of Valsalva, the left sinus, posteriorly next to the non-coronary sinus, and at an angle, but it's not intramural. You see the bifurcation of the left main is seen there, or you can suggest it. You see that? Just go back. Yeah. It could be intramural, but very short segment of intramural. Yeah. Could you ever do a cross-section of this just short after the ostium?
Could we ever, I didn't follow that. Could you ever do what?
It would be ideal when you have these conditions to have a cross-section of the proximal left main, the first 2-3 millimeters, in a cross-section at 90 degrees from this plane. This is the horizontal almost. You want to do vertical along the wall of the aorta and cut through the coronary artery to see if there is a cross-section. The problem of the CAT scan is it doesn't distinguish between intramural and extramural course, but it suggests that it's an acute angle. That's indicative usually of intramural, but it's not proof. Nor it can show you the severity of stenosis, nor the mechanism if it's by hypoplasia or by lateral compression.
Right, so that's why he did the intravascular ultrasound. It looks to me like it is elliptical, not circular, but not very compressed, at least at rest. But with stress, the patient was having symptoms. So Aksoy sent this patient to surgery. Brada, what's the follow-up after surgery?
So the patient underwent coronary unroofing, and he was reevaluated for an outpatient cardiology clinic follow-up. Patient still has atypical chest pain. Patient underwent a repeat stress test. Her functional status improved by a few minutes. Her prior exercise stress test showed she exercised 8 minutes. Now she went up to 10 minutes, meds of 12. Her ST depression slightly decreased. Initially, they were 1.5 to 2 millimeters. She still has ST depression, but they're only about 0.5 millimeters.
But they did not do a bypass. They just did unroofing?
They just did unroofing.
Paulo, what would you recommend in that situation?
Did the surgeon describe the findings of the left main? Was it intramural?
So the coronary CT read by the radiologist, they said it did not have an intramural course. However, there was mention, according to the notes, that there was intramural course.
How long intramural?
How long what? How long what?
The intramural course.
How long was the intramural course? I'm going to try and bring up the operating note.
All right.
What's the next one?
259 3655. Lock.
We know if the patient had chest pain, the intravascular probe was inside the left main.
Okay, here's the operative report. Post-operative diagnosis: intramural left main coronary artery, unroofing of left main coronary artery to enlarge the coronary ostium, epicardial echocardiographic assessment of the ascending aorta.
Right.
Description of the procedure. The ostium of the right coronary, the ostium of the left ostium arose approximately 6 millimeters from the commissure between the left and right sinuses and arose within the That's the left and right. That's the left and the non-coronary, isn't it?
Correct.
Okay, a 3 millimeter probe would not pass into the ostium. And a 2.5 millimeter probe was inserted in the ostium, and the left main was de-roofed by removing all tissue of the sinotubular junction superficial to the coronary artery until the level of the bifurcation was reached. The wall of the left main coronary artery was stacked up with the remaining wall of the aorta with interrupted sutures. The orifice was thus enlarged from a slit-like orifice. Isn't that interesting?
Yeah.
Slit-like orifice to an area approximately 5 by 4 millimeters. The ostium of the LAD and of the circumflex could be clearly seen within this, and roofed left main, and the incision had been extended almost to the bifurcation. And then they put probes down each one. So that's interesting that he actually saw it as a split. Where
Yeah.
I think what happens maybe is the IVUS catheter puts a guide wire bias on the artery and maybe even supports it or stents it open. Because it didn't look that tight on the ultrasound, but again, it's a volcano system ultrasound, which is inferior quality to the rotating catheters.
Could be that the guiding catheter was advanced subselectively into left main and opening up because the guiding catheter is very similar in profile as this artery.
No, the guiding catheter was back in the aorta. You could see that on the ultrasound, so that he had pulled it back, and it was just the ultrasound catheter coming out from the left main to the aorta.
Very good. So quickly, she was improved, but not much.
She was improved. I didn't hear the question.
How important and clear was the clinical improvement? Because by stress test, it's difficult to be sure.
She still had atypical chest pain, but overall her exercise stress test that she had after the coronary unroofing, it still showed abnormal EKG changes, 0.5 millimeter ST changes, ST depressions. However, she was.
So here's a note from December 11th from Aksoy, who saw her with, he says, typical chest pain, an abnormal stress test, status post-unroofing, recovered well from surgery. She continues to have pain with moving her body. That's chest wall pain, but felt a bit better with exertion.
There's two
Had some chest pain near the clavicles with running, and she still does not feel up to speed with exercise tolerance. But and that those pains were similar to those prior to surgery. So I'm not sure that maybe it's not clear how symptomatic or that the symptoms were really from this left main, but it certainly was bothersome. And the findings of surgery suggested that it should be done, that it was foot-like.
2 months after surgery.
It's very hard to hear you, Paolo. Is it possible to speak into a phone?
Yeah. Apparently, it's only 2 months after surgery. No?
Right. So some of her pain, I think, is chest wall pain.
But
her exercise capacity was better, so that's good too.
Maybe in the future it's better to do a PET scan. A PET scan is more precise for speaking.
Uh-huh.
By the description, it looks like if this was a problem, it was solved. It's very good.
Yeah.
An unusual case.
All right. Well,
these are cases of anomalous origin of minor degree within the proper sinus of Valsalva, but with an intramural force. And this is something that normally is not recognized as causing stenosis or chest pain. So it is a very important case, and we want to actually include it in our series when we review this subject. And we have 7 different locations of the coronary artery intramural force and stenosis in our collection.
Dr. Angelini, I'm sorry to interrupt, but your voice is coming across very garbled. I think Dr. Tobis said he's hearing it the same way. I don't know if there's any alternative method of speaking, but it really is incomprehensible.
Is it better now?
Yes, it's a little better now.
Basically, we are reviewing these chapters of coronary anomalies, anomalous origin of the left coronary artery with intramural force, that globally we call the left account. A few cases. Can you hear me?
No, you're kind of more like you were earlier now.
can you pick up the phone and speak directly into the phone instead of a speaker?
We are in the underground, and the phone signal is very poor.
Signal down here.
What? You can? Yeah. Let's see. We have another e-phone that probably works. Give me the phone number for the system. What is the number?
Web seminar call-in number.
All right, let's try.
So that's 702. Okay. 489-0008. And then you.
Let's try, because if we are close to the computer, it will interfere.
Okay. And the access code, you need to put that in. Are you ready?
The access code.
290 349 001.
Apparently, it doesn't work.
Okay.
Are you using a telephone in Los Angeles?
Yes, Paolo, I'm using a phone. There's no microphone.
That's probably the reason there is interference.
Uh-huh.
Dr. Angelini, when you're speaking right now, it sounds loud and clear. So I don't know if whatever you're doing now, you can continue.
Good. We're using now a cell phone.
Well, that's better. That's working.
All right. Let's continue then with this conversation.
So,
Can you hear me?
Dr. Angelini, we didn't hear much of anything, any of your prior thoughts very well. So anything you said before that you think is pertinent, you may want to repeat.
Okay. Here, I'll show you.
Can you hear me?
Yes.
Very nice. Now it's better.
Yes.
I can hear your voice very clearly.
Good. So, could you just comment on this case, maybe summarize what your thoughts are?
So summarizing, we have atypical pain in an adult with a congenital condition. We have a partially positive stress test, not very specific like the EKG, but not with localized sort of stress test. And then we have an anatomy that can justify, at least to suggest the possibility of a left main stenosis by hypoplasia more than lateral compression, but probably both. But hypoplasia, I think, is the dominant feature. Hypoplasia, I think, when I saw the original hypos, follows down also in the LAD. The LAD is about 2.5, but the LAD is even bigger than the left main. Mm-hmm. Spasm, if it is intramural, cannot occur. There is no media that can cause spasm around the coronary artery. It's the media of the aorta that is around an ectopic artery. So most likely this was stenosis by hypoplasia. The anomaly is within the proper sinus, but it is something that we have recognized as possible. We had two cases of one of sudden death during a marathon and another one a late occurrence around 56 years of age of unstable angina and congestive failure because of this mechanism. Ectopic thing within the left sinus of Valsalva, but is quite severe, acquired or developed a more serious stenosis anomaly of the left coronary artery from the proper sinus. So it is a new entity that we need to document better and follow better, because this could or could not be the final word of this on this patient. Do we know that there is no hypertrophy to cause the ST changes in this patient?
A baseline hypertrophy by echo?
Yeah.
Let me see. Imaging.
I think I remember there was none.
Transthoracic echo. Let's see. Yeah. It says normal thickness.
All right. So it is credible that there can be a left main to justify the presentation. The fact that there is non-typical pain is not unusual, and the reason why a patient with this condition would develop pain only late in their life at 48, or what is she, 48?
Yes, 48 years old.
It's usually hypertension. They develop hypertension and enlargement of the aorta, and what is intramural becomes more severely stenotic. But by compression, not by hypoplasia. Hypoplasia is congenital, and it should not increase with the age.
Very interesting.
All right.
Good. Thanks,
Very
Paolo.
good.
I appreciate the input on that.
Very good. We have a case on the similar subject. Who is next, Eric? Is Eric still listening?
Yes, we're here. We have a case that's quite different. If you want to move on to ours.
Yeah.
Okay. I'm going to introduce our speaker. It's Kathleen Evans, a third-year fellow that's been working with us in advanced imaging.
Artery sections, and so they don't get atherosclerosis. There's no
Media, yeah, interesting.
Can everybody see the screen?
Yes.
Okay, I'm going to pass the mic over to Dr. Evans.
Hi, I'm Kathleen Evans. I'm a third-year fellow over at Largo Medical Center. And over at Largo, we had this case come up. I'll just go ahead. This is a 71-year-old African-American male. He came in from a skilled nursing facility, and the staff reported that he had a 16-pound weight gain and a sarca, basically. But if you ask him, he had no complaints, and he was a fairly poor historian. Past medical history, type 2 diabetic, chronic kidney disease. However, his presenting labs were very good. He had a history of needing dialysis transiently for an unknown reason. They think maybe vancomycin induced. Also has a history of DVT, hypertension, arthritis, peripheral vascular disease with a left transmetatarsal foot amputation and no documented cardiac history. He again came in with a 16-pound weight gain over several weeks. He resides in a nursing facility. He's not very active. He denied any chest pain or shortness of breath. Family history, mother and father with diabetes. Social history, again, he lives at the nursing facility, remote smoker, remote alcohol abuse, which I'll show you evidence of in a minute, and denies drug abuse. Review of systems, I've already discussed. Again, he was a very poor historian. Medications, vitamin C, aspirin, Pepsid, iron, metoprolol, Norco for pain, Flomax, and Levemir. He had an allergy to Zosyn. Vital signs initially, blood pressure 139/77, heart rate 79, respirations 19, and statting 100%. On physical exam, he was fairly somnolent. Noted while he was sleeping that he would have short episodes of apnea. Nobody documented JVD or Bruy. On exam of the heart, there were no murmurs appreciated, no gallops, and he was regular. Pulmonary, he had poor effort and decreased breath sounds. And again, extremity showed anasarca. He had clubbing. He had a right below the knee amputation, left foot amputation, and left heel ulcer that was from a left heel ulcer. I don't know what that is. Okay, so these were the initial labs. Sodium was 133, K 4.5. Again, the BUN and creatinine were normal. Initial troponin was normal. I did get the total bilirubin. Direct bilirubin was 0.49. INR was elevated 1.58. Albumin 2.6, which is low. Platelets were okay, 206, PT 17.6, and PTT 42. This was his presenting EKG, showing right bundle. He looked like he might have some PACs. Echo.
He's not 8-year fit, no?
No.
Do we need the telephone? I have the impression there was UCLA and the telephone.
One of the first tests that we had was an echo before we actually had the consult. And I'm just going to show you a select few just to show his ejection fraction. So you can see he had a depressed EF, moderate size pericardial effusion, and also a pleural effusion. He was also fairly dilated.
That's okay.
Okay, so EF was about 35–40%. He had some interventricular septal flattening. RV and RA, LA was severely dilated. MR was only mild to moderate, and he did have that effusion. Yeah. So we decided to take him to the Cath lab just for the known new cardiomyopathy. And I'm sorry, these images load slow. Okay. This was the first shot. It's automatically going.
Yeah, I think it's set to just run. You want to do it, you can go to Data Manager and go to Series. And then, yeah, now you can pick them. Yeah, just remember to.
Okay.
Can you see these okay?
Yeah, it's a little interrupted, but it's clear.
Okay.
Yeah, I can see them too.
We don't see very well the end of all this fistulous flow.
Some of them were cut off abruptly, prematurely, I should say.
So is it a fistula going into the pulmonary artery or some other place? Because I can't tell that from here. It almost looks more like this huge ectasia of the left main LAD, and then almost like a pseudoaneurysm.
Yes.
That's all fusiform?
Yes, it is. They had a hard time distinguishing if it was a fistula to the PA, and after this, looked back at the pulmonary angiogram that they had gotten in the ER to verify that.
Definitely, this is not going to the PA, but it must be going to a venous structure on the back of the heart, possibly the posterior cardiac vein or the coronary sinus.
According to the CTA, they did see a connection of it was an anomalous RCA to the PA, to the main PA.
From the
Did we
right
see the...
From what we've...
Now it's the right.
From what we thought it was retrograde flow from collaterals on the left to the RCA going back up to the pulmonary artery.
That's called anomalous origin of the right coronary artery from the pulmonary.
Correct.
Okay. That's what it is then. It's not primarily a fistula, but ectopic origin with fistulous flow to the ectopic origin of the right coronary artery. Yeah, that makes sense. But
I don't see that visualized. I don't see the right coronary artery. Do you have it? Any pictures of the right?
Yes.
I guess you'd have to do it from the pulmonary artery. I don't know.
it should be seen very well by CAT scan, but by angiogram it's so magnified that you don't see the pulmonary artery. The typical thing here is that there are aneurysms of the left main, LAD, circumflex, so the whole system is subject to fistulous flow. And there is no clear runoff. It's not clear if it goes to the coronary sinus, but it could be very well be to the right coronary artery if it is ectopic origin from the pulmonary. But we don't see, you see, this is the distal right coronary artery, but it's very typical in these cases to see that the left main is much larger than the right, even though the right is the ectopia. But when you see these cases in late age, is the right coronary artery has flow mainly retrograde to the pulmonary more than to the myocardium. You have the CAT scan?
I do, but unfortunately the CD is not loading, and I can't get it to come up remotely either.
This should be the diagnosis, even though it's not well shown.
But usually those patients are very symptomatic. This is amazing. And heart failure. So Paolo, how does this person live to 70 years old?
Well, this is not unusual. The majority of these patients have no symptoms, and if they have some symptoms, it's only in the early age, in the newborn stage, in cases of very large right coronary artery. This is where you can see the best. In this last picture, pulmonary artery.
Right there.
Let it run to the end.
The right coronary artery.
It's still the right coronary artery, but the pulmonary is cut off.
Yeah, I can't tell.
So if they have an episodic ischemia is in the early newborn stage, when the pulmonary pressure comes down after birth, periphery of the right coronary artery becomes ischemic. In the usual patient, as this comes with the normalizing of the pulmonary pressure, that is high before birth, but it becomes 1/4 of the pre-birth after birth, it is usually well tolerated. In the adult age, there may be a right ventricular dysplasia or ischemic transformation of the right ventricle with the cardiomyopathy there. So they become ischemic with the cardiomyopathy more than acute infarction. It's rare to have pain. A stress test, a nuclear stress test, will frequently show either scar or mainly ischemia of the inferior wall of the left ventricle. The right ventricle, unless there is pulmonary hypertension, will not show ischemia by the stress test. But this is a case with the presentation of right-sided failure for ligation. This is a very simple operation. It's off extracorporeal circulation with a mini thoracotomy, 2 inches of intercostal approach in the right side. You can ligate the right coronary artery, and this is all this patient will need. There's plenty of collateral circulation to the myocardial flow in the right coronary artery, and this will improve the nutrition of the muscle without creating infarction or If there is a problem in the long term in this patient, is from the aneurysms of the left coronary artery that can cause mural clot. If you eliminate the flow to the pulmonary artery, this enlargement of the left coronary artery will not have any more reason for being, and lower flow may cause a tendency to clot. So this patient probably will need a long-term anticoagulation. Obviously, the rest of the body is deteriorated with the severe peripheral vascular disease. I don't know what the outlook is. But if there is an indication clinically to do something, this is very simple to do and is worthy trying because it probably will improve. In the very last picture you see the pulmonary artery. In the very last picture of this sequence.
Paolo, can you put a vascular plug in the right coronary artery from the pulmonary artery?
I tried. I tried, and I put a catheter. I was interested at that time to take the oxygen saturation in the blood draining into the pulmonary artery, and with the diagnostic right coronary catheter, we could enter with a small catheter into the fistula or in the ectopic origin artery and get the saturation that was equal systemic. So there was basically all fistulous blood. Nothing was coming from the myocardium. But potentially you can advance a coil. Yes, you can. It's very difficult and surgical. Yeah, that's the part. In this picture you can see the pulmonary filling. Surgery is so much simpler and easier and low risk and with extracorporeal circulation. That is the favorite procedure to do if you need to do anything in this patient.
So it would just be a matter of ligating the right coronary, period?
Now you have a bad forecasting. You're interrupted.
Can you hear me better now?
Much better.
Okay. So surgical-wise, it would be fairly minimally invasive, and it would just be a matter of ligating the right coronary artery?
Can you hear? Why? Yeah. Yeah, the ligation would be in the proximal right coronary artery that comes from the pulmonary trunk.
Okay.
And it's something that can be done with the minimal approach surgery.
Okay.
It can be both ligated or coiled, but it's much easier to ligate it in surgery than coil.
Okay. We did get a right heart cath and pulmonary angiogram if you're interested in seeing those.
We couldn't hear.
We did get a right heart cath with some pressures and a stat run, as well as a pulmonary angiogram. So there's a step up here.
The end-diastolic pressure of the right ventricle. The end-diastolic is 23, and the right atrial pressure is 31.
That's what they recorded.
That's really amazing and difficult to believe, but it could be. But 31 in the right atrium is very high. Is the mean pressure of the right atrium?
That's what they recorded in the report, yes. It may have been misdictated.
Looks like the problem is mainly in the right ventricle.
Okay.
That is consistent what we thought, but is a step up from 37 to 68, showing a 2-to-1 shunt. It's a huge pulmonary circulation for this fistulous system. Evidently, there is a lack of proper. Oh, look at that! An injection.
Cool.
Were you expecting the fistula with prograde flow from the pulmonary?
We were hoping to see something more, but this is what we got.
Pretty cool.
Should I slow it down some?
Mm-hmm.
Oh, that's going into the left atrium. I think the first one's the. Did we lose them? I don't hear anybody talking.
I think this one's, you see it go all the way. It's not a brisk injection, unfortunately. You see the whole RV.
It's so diluted out.
Yeah, it gets so diluted out.
It's gone.
Can you still hear me?
Where'd everybody go? They sound very quiet.
Yeah.
It says connecting to audio. Turn that off.
To try and close some internet apps, so try closing this and the Centrix.
We're connected back to Cuba again?
Yeah.
Is that right? That's pretty exciting. Take my boat down there.
Yeah.
Go to Havana.
That'd be great.
Take a midnight cruise.
You heard about that guy the Coast Guard rescued? Did you see that story?
No.
Rescued a guy.
I can't wait to go to Havana.
It says connecting to audio. On air.
You can write to him.
Can anybody hear us?